Hello, everyone. What I'd like to discuss with you today is pre-hospital conclusive diagnosis, treatment, and precise patient routing with mobile stroke units. So treatment of stroke patients is a very wide coordinated effort. And what it needs for optimal stroke care is a coordinated effort from many team members. That starts really in the pre-hospital setting with EMS and then handed off into the emergency room field and working with nursing, physicians, technologists, and so forth. And stroke neurology is very important in this setting, the stroke coordinator, the radiologist, the interventionalists, cath lab staff, and the intensivists. However, everything starts in the pre-hospital setting. So going on to the next slide, each system of care is specific and different, and each system of care is unique to the local infrastructure. And in Los Angeles County systems of care where we operate, there are over 10 million inhabitants of Los Angeles County. And in these, we have 29 public providers of ALS services with distinctive exclusive operating areas, meaning multiple fire departments and multiple ambulance companies running 911 calls. All of these operate differently, they dispatch differently, but they all in the field then operate under the LA County EMS regulations. And that's really important because how do you involve mobile stroke units or pre-hospital units in the very hyperacute phases, and how do you dispatch them appropriately to likely stroke calls? At the current allocation of resources, what we see in our departments in the field, we see a fire engine responding to every 911 EMS call, a rescue ambulance, plus or minus an additional transport ambulance. As you can see here, this is what the scene may look like now for a regular 911 call. And why is it important to get patients to the right place first? Is that we know that patients who arrive to the wrong level of care hospital, who need a transfer of care, end up doing worse in the cases of large vessel occlusion patients who need time-sensitive treatment. So what our goal is with mobile stroke units is not only to treat patients, but to identify the most vulnerable patients for deterioration and to route them to the appropriate level of care conclusively from the start. So in Los Angeles County, we use a Los Angeles motor scale called LAMS. This motor scale assesses for weakness, and it's a pure motor scale. It looks for weakness in the face, the arm, and the grip. Paramedics use this scale, which has an over 81% sensitivity and an 89% specificity for predicting large vessel occlusions. So patients with suspected large vessel occlusion syndromes will get rerouted to higher level of care, which is being the nearest comprehensive or thrombectomy capable center if they score a LAM score 4 or above. So they will bypass the nearest stroke center, that be a primary stroke center, and then go directly to a comprehensive stroke center or thrombectomy capable center. However, moving beyond this to conclusive diagnosis in the field, mobile stroke units are instrumental in getting the patients to the right place from the get-go. So in essence, mobile stroke units are really bringing the hospital to the patient. And in our diagram, which we've seen before, detailing all of the essential coordinated team efforts for care, mobile stroke units are occurring in the pre-hospital setting. And at the University of California, the Arlene and Henry Gluck Mobile Stroke Rescue Program was a public-public partnership for innovative stroke care in Los Angeles County, and it serves as a shared regional resource of the county. Remember, I told you there are over 28 911 EMS providers, and they each operate in exclusive operating areas. For mobile stroke units to be effective and treat the greatest number of patients at risk, they have to be able to operate to serve patients within a 10 to 12 mile radius. And depending on the geography, that may be multiple fire departments. So as a shared regional resource of the county, we're able to operate with all of these fire departments in an Artel catchment of 10 to 12 mile radius at the same time. So what are the capabilities of mobile stroke units for anyone in the group who's not familiar? Basically, each mobile stroke unit is set up a bit differently, but each have a different setup for team members. And in our specific mobile stroke program, we have a vascular neurologist who's in person or by telemedicine there for the calls, a firefighter paramedic, a critical care nurse, and a CT technologist. We're able to conduct laboratory testing inside of the unit with Chem 8+ and CoaguCheck, and the imaging capabilities using the neurological serotonin and using RAPID for post-processing of the CT angiograms, we're able not only to look at the parenchyma of the brain to determine whether or not there are hemorrhages or not in the brain tissue, but we're also able to confirm large vessel occlusions, aneurysms, and other vascular anomalies. In terms of treatment, so that's the first important part that I wanted to impress upon you. Mobile stroke units not only help for treatment, but they help for diagnosis, because it can determine which level of care hospital patients need to be triaged to. And additionally, after the clinical exam, the objective evidence from the CT and CT angiography, mobile stroke units have the capability of administering hyperacutely in a time period where we've never seen patients treated before, IV TPA for ischemic stroke, clot busting medication, and for hemorrhage reversal, patients' hemorrhage can be reversed if they're on blood thinning medications with Kcentra, Praxibine, or Ednexel. So in our demonstration project phase, our mobile stroke unit operates in 3 distinct geographic sites of the county, each of them within a 10 to 12 mile or 20-minute radius. We have multiple fire department partners in each region. And our mobile stroke unit is activated on a dispatcher impression of stroke. Dispatcher impression, when I refer to that, is when someone calls 911 and the call taker makes an impression of what the disease state is. They may call it a stroke. However, in the proper clinical scenario, we've also dispatched our specialized regional resource to first-time seizures, because that could be a first presentation of hemorrhage, syncope, altered headache, blood pressure issues, focal neurologic, sick person, or other. All of these we have dispatched to, and the outcome was a provider impression of stroke in the field. So now to talk about pre-hospital diagnosis, treatment, and routing. Again, using the Neurologica scanner, the serotonin scanner, and we have post-processing with rapid AI, we're able to not only see the parenchyma of the brain or the tissue of the brain, but we're able to have a reconstructed view of the blood vessels of the brain. And as you can see here on the screen, this CTA density map references side to side and tells you basically here of the normal side, what percentage is the abnormal side. So in this case, for example, there's a middle cerebral artery occlusion, and there is a less than 45% foliage of blood vessels or density of blood vessels compared to the normal side. And in the hospital setting, this can be used for also looking at perfusion, but currently on the mobile stroke units, we're not doing perfusion testing. So to focus first on ischemic stroke, which is the majority of strokes we see, in general, over 87% of strokes are ischemic in nature. In these ischemic stroke, the medical treatment is typically with IV TPA, and the endovascular treatment is with mechanical thrombectomy. Patients who need mechanical thrombectomy, they constitute about 35 to 40% of all ischemic strokes. The reason why these large vessel occlusion patients are so essential to get to the right place fast is because these stroke states are severe in nature. They have a 4.5 increase in mortality, fold increase in mortality, there's 3-fold increase in decrease in functional independence. What you see from this graph exemplifies the concept that time lost is brain lost. So in acute ischemic stroke patients, over 2 million neurons are lost for every minute of ischemia. What you see here on the y-axis is the probability of clinical outcome. So the higher, closer to 1, means the patient will do better. What you see on the x-axis is the time from the onset of symptoms, and you see this correlative relationship. So the earliest somebody can be treated, so this is at 200 minutes, just at the axis beginning, 200 minutes from stroke symptom outcomes, the odds are highest for them to have a good clinical recovery. And as time goes on at 400 minutes, that significantly decrements. This underscores the importance of time. So in our mobile stroke unit, we try to look at the field routing that paramedics would normally have versus what we've been able to do with actually diagnosing conclusively patients. And looking at LAM score, remember from what I told you that LAMs 4 and 5 are patients who are considered to be most likely large vessel occlusion patients and would be rerouted. Patients who are LAMs 0 to 3 would not be rerouted in normal paramedic care. So looking at our number of endovascularly treatable lesions, we had actually 47% of these patients to be LAMs 0 to 3. Again, this underscores the importance of having conclusive imaging. When we have a CT angiogram showing an M2 vessel occlusion or a basilar occlusion, and that patient still does not meet LAM's criteria for rerouting, we reroute in the mobile stroke unit to higher level of care based on conclusive evidence. So the goal is improving also door to puncture time. It's not only what we do in the ambulance where we try to work very fast and very hard, but our goal is what we do is when we find a large vessel occlusion, we pre-notify the receiving hospital neurointerventional team in order to save time and improve clinical outcomes. And we collaborate with each hospital to coordinate that. So I'll start by showing you now some examples of some cases in the field. And what you can see here is a 46-year-old gentleman. He had an acute onset of aphasia, dysarthria, right facial droop, and right arm more than leg weakness. And that patient, although young, the paramedics, for them it's atypical to see young patients with stroke symptoms. And although his motor symptoms were very mild, his LAM score was under 4. He had severe aphasia, which is disabling. The patient received IV TPA within 62 minutes of last known well time. To put that in reference, we always talk about door time and trying to get patients TPA earlier in door time, and trying to get under 1 hour, under 45 minutes, under 30 minutes. Imagine this is 60 minutes or 62 minutes from last known well time. That cuts out all of the time of transport, handoff of the hospital, getting consultants to come by in the hospital, moving the patient to a different physical facility in CT, the nurse mixing up or the pharmacist in the hospital mixing up the TPA afterwards. This forgoes many, many minutes of time, which will lead to improved patient outcomes, we hope. So you can see here in the non-contrast CT where the yellow arrow points, a hyperdense vessel sign in the Sylvian fissure, and this correlates with the CTA reconstruction that you see that there's a cutoff of an M2 branch of the left MCA, and you can see that the rapid post-processing imaging also detected that. This patient luckily had pre-notification of the neurointerventional team in the field after he received TPA. His door to puncture time in the field in Los Alamitos Medical Center was only 15 minutes. So imagine our door to puncture time, we always aim for at least to get under 60 minutes, or in many cases, people are getting under 90 minutes to go to cath lab and having the groin puncture. This patient had only 15 minutes. So that's really remarkable, and I think that speaks volumes to the benefit of mobile stroke units even for diagnosis. This next patient, showing another MSU to thrombectomy patient, is near and dear to my heart as a stroke interventionalist as well. This was a patient treated by my colleague, Dr. Barr, on the mobile stroke unit, and this patient with rapid post-processing showing a severe reduction in blood vessel density in the left M1 division. You can see that there's a lack of flow here, signifying where the clot burden is. This patient I received in Long Beach Memorial Hospital as a thrombectomy candidate. We removed the clot, and as you can see here, this is the clot burden. We use solitaire stent retriever for this patient, and here's the pre, where you can see no opacification in the M1 portion, and post, where you can see return of flow. And patient did remarkably well. He was aphasic and hemiplegic and was discharged with the hospital with very, very mild sensory deficits and very mild word finding difficulties. So this again underscores the importance. And this patient that you can see next, again, another picture of what we see in the field, showing a patient whose LAM score was less than 4. This patient would have not been otherwise rerouted for higher level of care. He received IV TPA of 66 minutes from last known well time. So again, this is LAMs of 1, and CTA shows clearly an endovascularly treatable lesion. This patient had a pre-notification for the neurointerventional team and had a TICI-3 recanalization by us bringing the hospital to the patient. In going through further scenarios, this is an 89-year-old woman with a history of right MCA stroke. This was a dispatcher impression of unconscious. and a provider impression of ischemic stroke, which goes to show you that the call taker type is not always the accurate type. So one has to really work within their system of care of how to dispatch mobile stroke units. This patient's LAM score was 5. Her stroke scale was 33. She had a right facial group, right hemiplegia, and aphasia. And her imaging demonstrated a right carotid artery occlusion. This patient was treated by my colleague, Dr. Victor Zader at Long Beach Memorial Hospital. He was pre-notified of the ICU occlusion findings. The paramedics, because the patient was unconscious, did not note the focality and symptoms. However, based on our exam, we were able to show that the cortical signs of gaze preference and indirect signs of weakness, and able to take this patient and directly to mechanical thrombectomy. This patient is a 60-year-old patient who was dispatched as a syncopal patient, and this highlights for you the importance of mobile stroke units being in the field. With paramedic education improving with time, the paramedics recognized signs and symptoms, and even though it was dispatched as a syncope, they added us to this call. This patient's LAM score was 5, her stroke scale was 19, mostly aphasia and right hemiplegia. Her imaging demonstrated an MCA clot and the parenchymal imaging. She got TPA in the MSU. Her stroke scale upon arrival to the hospital went from 19 to 5, and at 24 hours, her stroke scale was 1. This is another gentleman with vascular risk factors that are unknown or no vascular risk factors, dispatched of stroke. Again, he has a LAMS less than 4. He had a stroke scale of 5. The M2 looked like it's focally, M2 branch of the middle cerebral artery looked like it's focally attenuated and flow. And you can see here on the rapid post-processing that lesion here at the M1, M2 bifurcation. And the patient actually also had a subdural. So this goes to show you parenchymal imaging is extremely important. We can determine whether there is an extent of hemorrhage or only ischemia. So with that, I'll end with looking at hemorrhagic stroke patients. Hemorrhagic stroke constitutes about 13% of all strokes that we see in the field, and that may be hemorrhage because of parenchymal injury, subarachnoid injury, subdural, or epidural injury. And looking at our LAMS distribution, again, for routing of patients. Although LAMS was really made for routing large vessel occlusion patients, it was validated against TA occlusion and proximal M1 occlusions. It was not validated to detect now endovascular treatable lesions, which are more distal, like M2 occlusions or posterior circulation syndromes. So we've had a total of about 13 intracranial hemorrhages. Of those, the majority were LAMS 0 to 3, and the minority LAMS 4 to 5. This is a patient presenting with a stroke scale of 5 and a LAMS of only 1, and primarily aphasia and facial droop, no other motor symptoms. Patient actually walked outside of his house to the 911 gurney. He was admitted 40 minutes from last known well time. He had hyperacute initiation of hypertensives. Given the parenchymal hemorrhage, you can see here on the CT imaging, the patient was loaded with Keppra in the field as a prophylaxis for seizures. He was routed to comprehensive stroke center away from primary stroke centers based on conclusive imaging. Again, his LAM score would have taken him to a primary stroke center. This is a 78-year-old gentleman with vascular risk factors of coronary artery disease. His dispatcher impression was stroke, but upon arriving to the field, the paramedics were convinced that this was not a patient that we should admit because the patient presented with neck pain and acute nausea vomiting. And his LAM score was 0, and for them, this kind of dissuaded them in their mind because he had no functional motor symptom deficits, that this was not a stroke. However, when we demonstrated to them the exam in the bedside, the patient was ataxic with severe nausea and vomiting and neck pain. We told them that this is a patient we must admit, and in fact turned out to be a primary cerebellar hemorrhage with interventricular extension, again with a LAM score of 0. So this patient would have been routed not only to a non-higher level of care stroke hospital, but they would have been routed to MAR or the nearest available hospital and not a stroke center because the paramedics were going to ship as a GI illness. For this patient, we were able to load with nicardipine for blood pressure control to limit the expansion rate of the hematoma. We loaded with Keppra for anti-epileptic effect. We rerouted to comprehensive stroke center, pre-notified the emergency department, and as you know, these patients, they deteriorate quite fast. So when we presented to the ER, everybody was gowned and ready and intubated the patient right away. He proceeded to neurosurgical decompression acutely, and happy to say that he was discharged from the hospital doing well. If he had gone to another center and needed a return of transfer and so forth, I'm afraid the patient's outcome would have been very different. This is an 80-year-old woman, AFib on Xarelto, presenting with acute onset right MCA syndrome with a paramedic impression or dispatcher impression of stroke, provider impression of hemorrhagic stroke. Her LAM score was 5, stroke scale was 21. The CT revealed multiple densities of blood, and she was on anticoagulation. We, at the time, reversed with Kcentra, and we gave her nicardipine for blood pressure control and routed to CSC given the hemorrhage pattern. In this patient, an 83-year-old with on anticoagulation that you can see coming up next, here a dispatcher impression of altered, and the paramedics would have not known what the nature of this alteration is until a conclusive scan was performed in the field and showed subdural hemorrhage. This patient had a LAM score of 0 and was rerouted based on this conclusive imaging. This is an important, again, patient to show you the value of helping the paramedics understand better the nature of disease course. So this is a 67-year-old woman with acute onset headache, dispatcher impression of headache, provider impression of subarachnoid hemorrhage. She had no focal neurologic deficits, so stroke scale was 0. Her LAM score was 0. And other than the hemorrhage and nausea vomiting, as we saw in the cerebellar patient, no other indicators other than clinically sounded like a subarachnoid hemorrhage until proven otherwise. This patient was scanned, in fact, showed a perimesencephalic hemorrhage on the CT and a basilar tip aneurysm, and was rerouted for higher level of care, and fortunately did not re-rupture and did well and was discharged from the hospital. Ending with other diagnosis, so just to underscore that not all LAMS 5 patients are stroke patients. This patient had a dispatcher impression of shortness of breath, updated as a call type of stroke, and we were attached to this call. And the provider impression was seizure secondary to tumor. So this is 46-year-old presenting with left arm numbness on the day prior, prescribed a brace for carpal tunnel syndrome. On the day of presentation, he had a left facial droop, left face switching, left upper extremity flaccid paralysis, but then soon he generalized with a seizure in our unit. And as you can see here, the tumor burden and with significant edema around it. This is the, unfortunately, the MRI upon arrival to the hospital. He got transferred to Comprehensive Stroke Center for a higher level of neurosurgical care, showing that this was the first diagnosis of glioblastoma. So with that being said, I'd like to end with just saying that mobile stroke units are not only for IVTPA, they can help with conclusive diagnosis of cerebral and parenchymal lesions, as well as vascular lesions in the pre-hospital setting, and they allow for not only, again, hyperacute treatment, but precise patient routing to the appropriate level of stroke care. I'll end with that, and after Dr. Grada's talk, we'll be able to answer any questions anyone in the group has. Thank you.